Imagine your beloved older horse. Maybe they're just a bit slower, not quite as energetic as they used to be. You might notice their winter coat sticking around longer than usual, or maybe they're getting a bit of a thicker neck, that sort of cresty look. It's so easy to just chalk it up to, well, getting old, right? But what if those subtle shifts aren't just age? What if they're pointing to something specific, something you can actually treat and make a real difference in their life? Welcome to the Deep Dive. Today, we're getting into equine Cushing's disease, although the more accurate name is Pituitary Pars Intermedia Dysfunction, or PPID. Quite a mouthful.
It is, yeah. PPID is definitely more precise.
So for this deep dive, we've gathered insights from a whole stack of expert sources, top veterinary research, clinical experience, all focused on equine health. Our goal here is to really unpack one of the most common hormonal disorders diagnosed in horses. We want to simplify the complicated stuff. We'll cover everything from what's actually happening deep inside the horse's brain, right down to the practical steps, what owners can do for diagnosis and managing it long term. Think of this as your shortcut to getting really well informed on PPID.
Exactly. And everything we're discussing, it's grounded in solid veterinary science and real-world clinical practice. We're taking all that complex information and boiling it down into something practical and understandable for you.
Perfect. That's the mission. Okay, let's jump right into basics. What exactly is PPID? Our sources call it the most commonly diagnosed endocrinopathy that's a hormone disorder in horses. At its heart, it's described as a slowly progressive neurodegenerative condition. It primarily messes with a specific part of the pituitary gland, that tiny little gland in the brain.
Right, and there's a key point here that often causes confusion. We call it equine Cushing's, but unlike, say, Cushing's in dogs, which is often about the adrenal glands.
Oh.
In horses with PPID, the problem really starts in the pituitary. That's the main driver. Now, that pituitary dysfunction leads to high levels of a hormone called ACTH, which then tells the adrenal glands to produce more cortisol. So you do get high cortisol effects, but the root cause, it's pituitary.
That's a really crucial distinction. It helps frame the whole thing.
Yeah.
So if it's a pituitary issue, who gets it? Are we talking specific ages, breeds?
Primarily, yeah, it's our older horses, typically over 15 years old. The average age of diagnosis is actually around 19. It's pretty rare in horses younger than 10, though the sources do mention it can pop up as young as 7.
Okay, so definitely more of a concern for the senior crowd, mostly. And just how common are we talking? Is it like a 1 in a million thing? Or?
No, not at all. It's surprisingly common in that older group. The numbers reported are somewhere between 15% and 30% of horses over 15. That's significant.
Wow.
As for breeds or sex, really any breed can be affected. You might hear that ponies and Morgans seem to get it more often, but that might just be because they tend to live longer and are maybe more prone to things like laminitis, which is often linked to PPID, not necessarily a strong breed or sex link for PPID itself.
Gotcha. Okay, so let's shift from the what to the why. This is where our sources get really fascinating, talking about the brain's broken brake mechanism. To really get PPID, we need to look at that pituitary gland again. It has different parts, and a couple of them make this precursor molecule, POMC, like raw dough, maybe.
Yeah, good analogy.
But they process that dough into different final baked goods, different hormones. With PPID, it's one specific section, the pars intermedia, that starts going haywire.
That's exactly right. The cells in that part, the melanotroph, are normally kept in check. They're under what's called tonic inhibition by dopamine. Dopamine, the neurotransmitter. It's released by neurons coming down from the hypothalamus just above the pituitary. Think of it like a constant, gentle brake signal telling those cells, okay, slow down, don't overdo it.
And here's the kicker, the real aha moment from the research. PPID happens because those dopamine brakes start to fail. In horses with PPID, those specific dopamine-producing neurons in the hypothalamus undergo damage. Oxygen-induced injury and degeneration is the technical term. The control system breaks down.
Precisely. So when those neurons degenerate, they produce less dopamine. That means less inhibition, less of that brake signal reaching the melanotrophs in the pars intermedia.
The brake line's cut, essentially.
Kind of, yeah. And as a result, those melanotroph cells, they start to multiply. That's called hyperplasia, and they just go into overdrive. They churn out way more of those POMC-related hormones, including ACTH, but also others like alpha-MSH and beta-endorphin. It's this whole cascade triggered by the loss of that dopamine control.
Wow, okay. A cascade effect, starting from such a specific neurological breakdown. So how does all that internal chaos show up on the outside? What are the signs owners might see or maybe even miss at first?
That's a really important question because PPID is sneaky. The signs are super varied, they creep up slowly, and like you said earlier, they often get mistaken for just normal aging. It makes it tough, to separate normal wear and tear from a specific disease process.
So if the signs are so varied and subtle, is there like one classic sign, a big red flag that really points towards PPID?
Yes, absolutely. The most characteristic, almost pathognomonic sign is hirsutism. That just means an abnormal hair coat. We're talking a long coat, often wavy or even curly, that just doesn't shed out properly in the spring or summer, or it takes ages to shed.
Still looking woolly in July.
Exactly. In the early stages, it might just be some long hairs under the jaw or on the backs of the legs, maybe across the body. But in advanced cases, it's that full-on shaggy look all over. It's really unique to PPID, unless, you've got a naturally long-haired breed like a Missouri Foxtrotter or a Bashkir Curly.
Right, context matters. But for most breeds, that persistent winter coat in summer is a major clue. Okay, what about the most serious complication? The one that really impacts their quality of life?
Without a doubt, that's laminitis. It's often recurrent, it's incredibly painful, it's inflammation of the sensitive layers, the laminae inside the hoof, and crucially, it's very frequently linked to problems with insulin regulation, which often goes hand in hand with PPID. Laminitis is a huge deal for the horse's comfort and soundness.
Definitely a major concern. So beyond the coat and the risk of laminitis, what other systems get hit by this hormone imbalance?
Well, you often see significant muscle wasting. It's especially noticeable along the top line, the back, the hindquarters. This muscle loss, combined with weaker abdominal muscles, can lead to that classic pot-bellied look, even if the horse isn't overweight. It's due to protein breakdown.
Ah, okay.
And then there's abnormal fat distribution. You might see fat pads developing in weird places, like a really thick, hard crest along the neck.
The cresty neck.
That's the one. Or fatty deposits over the tail head, or even bulging pads above the eyes in the little hollows there.
What about basic things like drinking and peeing? Any changes there?
Yeah, increased drinking and urination, polyuria and polydipsia or PD are pretty common. Owners might notice the stall is always soaked.
Right, more mucking.
Exactly. The causes can be a bit complex, could be kidney changes, effects on water balancing hormones like ADH, sometimes even high blood sugar spilling into the urine. We also often see behavioral changes, things like lethargy, just seeming dull or out of it, maybe becoming unusually placid or docile. That might be related to those increased beta endorphins we mentioned earlier. They have opioid-like effects.
Interesting. And what about sweating? Can that be affected?
It can, yeah. Some horses show excessive sweating, hyperhidrosis, sometimes even if they don't have the really long coat. But much less commonly, you can get the opposite, an inability to sweat properly, which is called anhidrosis. That's obviously risky in hot weather.
And the immune system. I've heard PPID can affect that too.
Yes, that's a major consequence. The hormonal changes, particularly the elevated cortisol, can suppress the immune system. This makes them much more prone to recurrent or chronic infections. Things like skin infections that just won't clear up, nasty foot abscesses, sinus infections, even pneumonia. They might also carry higher parasite loads. And wound healing can be really slow. A small cut that should heal quickly just lingers.
Any impact on breeding animals?
Yes. For mares, it can cause irregular heat cycles, or they might stop cycling altogether. Stallions can experience reduced fertility. And then, in really advanced, thankfully rare cases, if the pituitary tumor gets large enough, it can actually press on nearby parts of the brain. That can lead to serious neurological signs, things like blindness, seizures, or problems with coordination, ataxia. It's a huge range of potential problems stemming from that one little gland.
Wow, that is a lot for an owner to potentially notice, especially since some signs are so subtle early on. So if an owner or vet does suspect PPID, how do you actually confirm it? What's the diagnostic process?
It's definitely a combination approach. You look at the clinical signs the horse is showing, you get a really detailed history from the owner. When did things start? How have they progressed? And then critically, you run specific endocrine blood tests. But testing can be tricky. The disease progresses slowly, and like we touched on, horse hormones naturally fluctuate with the seasons.
Right, the seasonal thing. So what's the main go-to blood test?
The most common starting point is measuring the basal ACTH concentration in the blood plasma. If that level is elevated, especially outside the autumn months, it's a strong indicator of PPID. But, and this is super important for owners and vets, how you handle that blood sample is crucial.
Okay.
Blood needs to go into a specific tube, usually an EDTA purple top.
Hmm.
Then the plasma has to be separated from the red cells pretty quickly, ideally within 3 or 4 hours. And then it absolutely must be chilled immediately and kept cold, usually frozen, during shipping to the lab. ACTH is incredibly fragile. It breaks down easily at room temperature.
Okay, so meticulous sample handling is non-negotiable for an accurate result.
Frick.
You mentioned seasonal variations affecting interpretation.
Massively. Healthy horses naturally have higher ACTH levels in the autumn, sort of late August through November, peaking around September. It's called the seasonal rise.
Huh. Why does that happen?
It's thought to be an evolutionary thing, maybe helping them prepare for winter, grow a thicker coat, store fat. But it means if you test a horse during that time, you must compare the result to reference ranges specifically established for that season.
Ah, okay.
Otherwise, you might misdiagnose a healthy horse or miss a mild case of PPID. Testing outside that autumn window can sometimes be clearer. Also, things like stress, pain, illness, even recent strenuous exercise can temporarily bump up ACTH, so you want the horse calm and relaxed for the blood draw if possible.
Timing, handling, season lots to consider for that one test.
Yeah.
What if the basal ACTH comes back kind of borderline, or the horse has early signs but the test is normal? Is there another option?
Yes, for those situations, early disease, equivocal results, or testing outside the tricky autumn period, the TRH stimulation test is often really helpful. It's considered more sensitive for picking up early cases.
How does that one work?
You take a baseline blood sample for ACTH just like before. Then you give the horse a small intravenous injection of a hormone called TRH thyrotrochine-releasing hormone. Then you take another blood sample for ACTH 10 minutes later, and sometimes a third sample at 30 minutes post-injection.
And what are you looking for in those post-TRH samples?
Horses with PPID have an exaggerated response. Their Pituitary Pars Intermedia overreacts to the TRH signal, releasing a whole lot more ACTH than a healthy horse's would. The guidelines usually state that an ACTH level over 110 picograms per milliliter at the 10-minute mark, or over 65 at 30 minutes, is highly suggestive of PPID. But again, timing matters. This test is generally recommended only from about January through June to avoid confusion with that natural autumn ACTH surge.
Okay, that makes sense. Now, we keep circling back to laminitis being such a huge risk factor. Is there a direct link we need to test for between PPID and the horse's insulin system?
Yes, absolutely critical connection. A really significant chunk of horses with PPID estimates range from 30% up to maybe 60% or even more in some studies also develop insulin dysregulation or ID.
ID, okay.
This usually means they have high levels of insulin circulating in their blood, often because their body tissues aren't responding properly to insulin anymore. That's insulin resistance. Sometimes they might also just produce too much insulin after eating sugars or starches.
And why is knowing about ID so important for managing a PPID horse?
Because insulin dysregulation is a major driver of laminitis risk. If a horse has both PPID and ID, managing their diet to control sugar and starch intake becomes absolutely paramount to prevent devastating laminitis episodes.
Right.
So it's often recommended to test for insulin status right alongside testing for PPID, especially if the horse has any history of laminitis or shows signs like those fatty deposits.
How do you test for ID?
You can measure baseline insulin levels, but often a dynamic test gives more information. A common one is the oral sugar test, or OST. The horse gets a measured dose of something sugary, like Crarolite syrup, usually after fasting briefly. Then you measure their insulin level 60 to 90 minutes later. A very high insulin response tells you they have insulin dysregulation and are at higher risk for laminitis, especially if fed high-starch meals or grazing lush pasture.
Okay, so diagnosis involve clinical signs, history, ACTH testing, maybe TRH stim, and definitely checking insulin status. Once you have that diagnosis, what's next? Is PPID curable?
Unfortunately, no. PPID is a progressive neurodegenerative disease, meaning the underlying damage to those dopamine neurons continues over time. There's no cure. So treatment is all about lifelong management. The focus is entirely on controlling the clinical signs, preventing complications like laminitis, and giving the horse the best possible quality of life.
What's the main weapon in the arsenal for managing PPID? What's the go-to medication?
The undisputed gold standard and the only FDA-approved drug specifically for equine PPID is pergolide mesylate. Most people know it by the brand name Presendi.
Pergolide, okay.
It works brilliantly because it's a dopamine agonist. Remember we talked about the lack of dopamine being the core problem?
Yeah, the break and break.
Exactly. Pergolide basically acts like dopamine in the brain. It binds to the dopamine receptors on those overactive pituitary cells and tells them to slow down, restoring that inhibition. This reduces the excessive production of ACTH and the other POMC hormones, bringing things back towards normal. It's like giving the brain's brake system a boost.
How's it given? Is it an injection?
No, it's an oral medication, usually a small tablet given once a day. You can hide it in a treat or a small bit of low-sugar feed. Dosing typically starts low. The standard starting dose is often around 0.0002 milligrams per kilogram of body weight, which works out to about 1 milligram, or 1 tablet, for an average 1,000-pound horse.
Yeah.
Then the vet monitors the horse's clinical signs like shedding, energy levels, and rechecks ACTH levels after a month or two, adjusting the dose up or down as needed. Some smaller ponies might only need a quarter or half a tablet daily.
And you said it's effective. How well does it work?
It's generally very effective. Studies show significant improvement in clinical signs in a large majority of cases. Figures like 65% to 85% are often cited. Some sources even say over 90%.
That's pretty good.
Yeah. Owners usually see positive changes, better shedding, more energy, fewer laminitis issues within about 1 to 3 months of starting the medication.
Are there side effects owners need to be aware of with Pergolide?
The most common one, though it doesn't happen to every horse, is a temporary loss of appetite, sometimes called the Pergolide veil, when starting treatment or increasing the dose. Usually, if that happens, the vet will advise stopping the medication for a couple of days until appetite returns, then restarting at a lower dose, maybe splitting the dose morning and evening. It often resolves. Other possible side effects are less common, but can include things like temporary lethargy, mild colic signs, or diarrhea. It's also worth noting it hasn't been specifically studied in pregnant or lactating mares or breeding stallions. And for competition horses, it's a prohibited substance under FEI rules.
Good to know.
Yeah.
Are there any other medications sometimes used if Pergolide isn't enough or wasn't used historically?
Well, historically, before Pergolide was widely available and approved, a drug called cyproheptadine was sometimes used. It's a serotonin antagonist. But research has shown it's much less effective than Pergolide for PPID. Sometimes vets might try it as an add-on therapy if a horse isn't responding fully to Pergolide alone, but it's not a first-line choice. There's also trilostane, which is licensed to treat Cushing's in dogs by blocking cortisol production. Its use in horses with PPID is really limited, maybe considered only in very specific severe cases, like horses with persistent laminitis and extremely high cortisol levels that haven't responded well to Pergolide. But it doesn't address the primary pituitary problem.
So Pergolides are really the main player. Beyond the medication, though, how important is the day-to-day supportive care? What else can owners do?
Oh, it's absolutely critical. Medication alone isn't enough. Supportive management is key to their overall well-being. Dietary management is huge. A foundation of good quality, appropriate forage is essential. And as we discussed, if that horse also has insulin dysregulation,
Right.
then strict control of non-structural carbohydrates, the NSC's sugars and starches, becomes vital for managing laminitis risk. That often means testing hay to know the NSC content, maybe soaking hay to leach out sugars, avoiding high grain feeds, and carefully managing pasture access.
Makes sense. Diet is tailored based on that insulin status.
Yeah.
What about other general care?
Good general husbandry is crucial. Regular, effective deworming based on fecal egg counts, keeping up with vaccinations, and really diligent dental care. Older horses often have dental issues anyway, and PPID horses need to be able to chew properly to maintain condition.
Good point.
Vigilant hoof care is non-negotiable, with regular farrier visits to manage foot balance and watch for any early signs of laminitis. For the horses with the heavy coats, regular body clipping, especially in warmer weather, makes a huge difference to their comfort and helps prevent overheating. And because their immune system can be suppressed, owners need to be really proactive about treating any secondary infections quickly. Skin problems, foot abscesses, respiratory infections, whatever pops up.
It sounds like owners really need to be observant and proactive partners in the horse's care team.
Absolutely. Owner education and vigilance are paramount. They need to know what complications to watch for those infections, subtle signs of foot soreness, any wounds that aren't healing so they can call the vet early. As for exercise, unless they have an active infection or a laminitis flare-up, maintaining normal, appropriate activity is generally good for them. And if muscle wasting or weight loss is an issue despite treatment, the vet might recommend adjusting the diet to increase safe energy sources, maybe adding specific supplements to support muscle health.
Okay, so putting it all together, the diagnosis, the lifelong medication like Pergolide, the crucial supportive care, what's the overall outlook? What's the prognosis for a horse with PPID?
With proper diagnosis and consistent management, the prognosis is generally considered good to fair for most horses. While we can't cure the underlying neurodegeneration, pergolide is very effective at controlling the signs. The vast majority of treated horses can achieve a really good quality of life, with those problematic signs like the coat issues, lethargy, and infections improving significantly, or even resolving.
So definitely not the immediate end-of-the-road diagnosis it might have seemed like years ago. How long can they live well with it?
Many horses diagnosed with PPID can live happily and comfortably for many years, often 5, 10 years, sometimes even longer after diagnosis, provided they receive consistent care. But, and it's worth stressing this again, the biggest factor influencing both quality of life and long-term prognosis is laminitis.
Hmm.
If laminitis can be successfully prevented or managed through effective PPID treatment and appropriate dietary and hoof care, the outlook is much, much better.
Hmm.
Controlling the PPID directly reduces the risk and severity of laminitis.
So managing the PPID is managing the laminitis risk, in large part. That really underscores the need for consistent treatment and monitoring, doesn't it?
Absolutely. It's not a diagnose, treat, and forget situation. Regular veterinary checkups are essential. This includes monitoring their clinical signs, checking body condition, and doing follow-up blood tests like ACTH levels. Initially, maybe every 4-6 weeks after starting pergolide, then perhaps every 6-12 months long-term, including checks during that autumn season to make sure the dose is still appropriate. The disease can progress or their needs might change seasonally, so adjustments to the medication dose are sometimes necessary. And of course, the owner's commitment, both emotionally and financially, to providing that consistent lifelong care is a huge factor in ensuring a good outcome.
So wrapping this up then, it's clear from our deep dive into the sources that equine Cushing's, PPID, while it sounds complex, is definitely a manageable condition today. It doesn't automatically mean retirement or the end of a horse's useful, happy life. With the right diagnosis, consistent treatment like pergolide, and that dedicated supportive care from the owner, horses with PPID can absolutely continue to thrive. This whole discussion really highlights how one tiny part of the brain, the pituitary, can have such enormous body-wide effects in a horse. Kind of makes you think, doesn't it? How many other things that we often dismiss as just normal signs of aging, whether in our animals or maybe even in ourselves, could actually be specific diagnosable conditions. Conditions that, if identified and managed, could lead to a significantly better quality of life. Maybe it encourages us all to keep learning, stay observant, and use that critical thinking to differentiate between what's truly just aging and what might be a health challenge we can actually address. Something to ponder.